Hello and welcome to Unstress Health. My name is Dr. Ron Ehrlich. Well, today we explore osteoporosis, and this is a theme that a subject that we haven't really explored on the podcast before, but we're also going to explore it from a slightly unusual perspective, because we're going to explore it from the perspective of a young man's experience with osteoporosis. My guest today is Dr. Tom Forfa. He's a medical doctor and an educator on a mission to bring 1,000 men out of osteoporosis by 2026. After successfully reversing his own osteoporosis naturally and drug-free, and surprising, as you will hear, his own endocrinologist, it's interesting to reflect on whether that changed the endocrinologist's practice or not, but I digress. Dr. Tom has gone from fracturing bones, and his story is a rather surprising and shocking one, to competing in his first powerlifting contest and returning to the potentially bone-breaking activities he loves, like snowboarding. Through his work, he addresses the often overlooked challenges men face for osteoporosis journey. They're not often associated with this issue. It's usually thought of as being a problem that affects women at a later age. And as you will hear, Tom's first experience was in his late 30s, but he provides practical insights that go beyond conventional therapy. It's a fascinating story. It's an inspiring story. I hope you enjoy this conversation I had with Dr. Tomasz Forfa. Welcome to the show, Tom.
Thank you for having me, Ron.
Tom, I like to explore two particular themes when I talk to medical practitioners. One is the impact that their own health has had on their health journey personally and professionally, and the flow-on effects to the public from that. But also, burnout is a big problem in medical world, in the health practitioner world, medical world. And I'm really intrigued to hear your personal story, your journey that's brought you to this point.
Excellent. Well, I think I've had a very unusual journey compared to most healthcare practitioners, especially medical doctors. So I started the usual way. I went through medical school, I did my internship, and then I started looking at different training programs. But throughout that time, I was becoming very kind of disillusioned with the delivery of healthcare. And I was becoming burnt out as well. And ultimately, I was a couple of years into my practice as a doctor. I was traveling, getting a bit of downtime, and I got the email saying, "Hey, are you coming back to the hospital or not?" And at the time, I was running a business. We were traveling with my wife, and I was able to kind of express all my creativity and live through all my values in a way that I felt was far more impactful through business and philanthropy rather than through medicine. And so I sent in my resignation to the hospital, and I haven't been back since, and that was back in 2014. And I thought I would never kind of be back into the actual practice of medicine until I was pulled back around 2020. Not because of COVID, but because of a broken bone, actually. I was riding a bike, and in between COVID lockdowns, and I hit a little ditch, slowly went over the top, fell over. Nothing shouldn't have been anything for a 37-year-old male. But I broke a wrist. And on its own, well, that's a little bit weird, but nothing to really be concerned about. But when you put into perspective, that was my third fracture in 18 months. Before that, I had rolled my left ankle and fractured it. I was doing a boxing class, holding a pad in my chest, and I punched it and broke a rib. And that weren't the only fractures that I'd had throughout my life. I'd broken the other ankle in 5 places from rolling it.
Wow.
I had broken multiple ribs, falling over on a snowboard. And again, all these things on their own. Well, okay. I fell over snowboarding on some ice. I broke a rib. So that's kind of to be expected. But when you paint that whole picture,
that's a lot of fractures.
It's a lot of fractures.
I've lost count there. But that sounds like at least 5 or more fractures.
I've lost count.
It's probably
around 8 or 9.
Right.
The wrists as well over the years.
Incredible.
And so it was at that point in 2020 that my GP said, you know what, let's do a scan of your bones, a DEXA scan, which is kind of like an X-ray, but it looks at the how much density there is in your bone, how much tissue there is in there. And it turned out that I had what's called early-onset osteoporosis. So essentially, I was an otherwise healthy 37-year-old male, but I had the bones of a postmenopausal lady of 65, which was a bit of a shock to me personally, and also to my GP. And at that point, that's what it was. It was a shock. But I thought, you know what, it'll be okay. I'm a healthy guy. I can work through this. And so I was referred to an endocrinologist, as usually happens in Australia. And he was sitting there scratching his head, wondering what is this? I usually see women after menopause, they're frail, and I'm making some kind of stereotypes here. It is generally associated with women, but there are all sorts of different reasons why it happens. And so he was scratching his head, wondering what's going on. And we did a whole bunch of different tests. And it showed up no particular cause for it. There were all these minor little potential causes, which I've realized kind of stacked up over the years. But what we did find, which was concerning, were 2 crush fractures in my lumbar spine. Wow. And it was at that point that I kind of fell apart. My belief in my body fell apart. I became afraid. Am I going to break my back? Am I going to break another bone? And this is what a lot of people experience with osteoporosis, no matter what their age. No one really thinks about it until you break a bone and you get a scan and they tell you you've got this disease, in inverted commas. And that creates a lot of fear and uncertainty and takes that confidence away. We stop doing all the things we love to do because, am I going to break something? Am I going to be incapacitated? Am I going to be a burden on my family? And so it was a shock to me, and I was working with a really well-meaning endocrinologist, but he kind of pigeonholed me into, well, I've seen these types of patients, you should take the medication. And from the way that I look at things, medications in my mind are kind of the last resort, if even we do it. And I thought, can you just give me 6 months to figure this thing out? Because something wasn't quite making sense. For my training in my medical degree, I knew that bones can strengthen. They do adapt to pressure, to different stimulus. And it didn't make, I looked at the medications, and as a young guy, there were some limitations at the time. You could only take them for a certain amount of time. And then once you stop, your bones don't stay where they are. They get worse. And not only do they go back to where they were, they can even go further than that, like into the red that compared to before.
These medications, Tom, are the bisphosphonates. Is that
there's a few of them, but bisphosphonates are the first line treatment, and yes, they are the ones that are usually recommended.
But you went to the endocrinologist and he looked into he reflected on his 15 years of training and all his medical knowledge. And of course, the first thing was to reach for the prescription pad.
Yeah.
This comes back to your first comment about the way healthcare is delivered, really, isn't it? But
that's it. And If I'm in a car accident, I'll go to the emergency department, give me all the Western medicine. When it comes to chronic issues, and osteoporosis is definitely a chronic issue, medicine is I don't want to offend anyone, but it's hopeless. It really can be. And so I said to my endocrinologist, give me 6 months. And he said, you know what, Tom, you're a doctor, you've got a medical background, I'll give you that 6 months. And essentially he said, his kind of prognosis was, Tom, we can only hope it doesn't get any worse. Here are the medications to hopefully prevent it from getting any worse. And I said, all right, we'll see how this goes. And so I dug into what I knew, which was just trying to make sense of why does osteoporosis happen? What is it about? What's going on here? What kind of research is out there? And also what happens for men? because it's osteoporosis is predominantly a women's condition. But then there is this certain percentage of men who get it who are very isolated when they do. And it is a very isolating situation, almost like a little bit embarrassing. It's like, oh, I thought this was a women's condition. And so I was trying to kind of figure out, firstly, how does it happen in women? And then kind of almost specialize into men, because it resonated. I needed to fix myself first. And so I kind of I kind of figured it out in my own mind, and I started implementing my own kind of
Well, Tom, before we go into the protocols, because obviously that's really important, but I do want to set the stage here because you looked into it a lot, and this is a topic we haven't really covered on our podcast. So I'd love you to give me some, what are the predisposing factors? What does modern medicine say causes osteoporosis? How is it diagnosed? I think that's interesting, too, because we're very good at pathologizing things as well.
Yeah.
But tell us, how do people get osteoporosis?
Okay, let's start with the definition of osteoporosis.
Yeah.
Essentially, it is when there's less bone tissue, and the architecture of the tissue deteriorates, of the bone tissue itself, at which point the bones become more fragile and likely to break. And so some small kind of impacts, like if you're just falling from a standing position, some people sneeze and they break a rib, some people shaking hands, it can get that bad.
Wow.
For others, there are other impacts. Essentially, the bones become more fragile, which might seem, so we break a bone. But the thing is, the first broken bone means you're 80% more likely to get another one. And then there's the recovery time, which is a big problem. It often happens in the elderly. So people over 50 usually, for men particularly, there is a 1 in 5 chance that a man over 50 is going to have an osteoporotic fracture in the remaining course of their lives. And it gets even worse when we have hip fractures. Hip fractures for men particularly, 1 in 5 men who have a hip fracture will pass away in the first 12 months.
Wow.
And so it could have dramatic kind of life expectancy effects and mortality and morbidity as a result. Now, traditionally, the way that we diagnose osteoporosis is we do what's called a DEXA scan, which your doctor will refer you for that. And you'll go, it's like an X-ray machine, and it scans usually your hip, your lower back, and your forearm in Australia as well, because those are the areas that break, and if they break, that's where we have a lot of the major.
But Tom,
problems.
when you have people who have fractures as you have, there's clearly an issue going on here. But many people receive diagnoses of osteopenia first, and then osteoporosis. What is the reference? You talk about this DEXA scan.
Yes.
What are they using as a reference to give people that diagnosis?
Okay, so when you get a DEXA scan, you'll get what's called a T-score. And a T-score is essentially comparing you to a healthy 25-year-old person of your gender and ethnicity.
Yeah.
Now, there is a whole lot of controversy about the use of T-scores in itself, but let me just give you the definitions first.
Okay,
so anything, if you've got anything -1 and higher, so negative 0.5 or in the positives, you're normal. But when you go to -1 to -2.5, you have what's called osteopenia, which is almost like pre-osteoporosis, if you will. It's weakening of the bone, but not to the extent where the statistics show that you're very likely to break something, which is essentially from that 2.5 onwards. And oftentimes, people will come to us with -3s, -3.5s, and it gets scarier the further it goes, because you're essentially your bones are more and more fragile the lower that number is, and so that's the traditional kind of way. And if there are any medical professionals watching this, that's how they would think about it. There is a shifting tide looking at the bone quality, which the research is showing is far more important than bone density. So just to differentiate those things, the T-score looks at the density, so how much bone tissue is in your bones. Now, it doesn't look at how that's structured. So a great example, what I heard recently, is from an American doctor called Dr. Andy Bush, and he compared a pencil to a piece of chalk. Now, if you think about a piece of chalk, it is dense. There is a lot of stuff in there, a lot of chalk in there, tightly packed. If you did a scan of it, it would be very dense. A pencil is not as dense. But if you were to drop both of them from a standing height, which one would break? The chalk. The pencil will be okay because the pencil has a better microarchitecture and structure of the different fibers. And that's what the research now is, and the kind of where the tide is going, is showing that it's far more important is the bone quality and the microarchitecture of the actual bone. But it's going to take some time before that tide kind of shifts, and it's people like yourself, Ron, who are bringing on people to talk about this that are going to shift that tide, which is really exciting.
I mean, I think what you've described in your own personal journey and people who break ribs by coughing or shaking hands is really concerning, and the statistics around hip fracture are really concerning statistics.
Yeah.
But there is a bigger picture here about how we do, in fact, pathologize growing old by comparing bone to a healthy 25-year-old. So I, who am now in my late 60s, sure as eggs, I would say, would have a different bone quality to a person who is 25. And if the answer to that preventatively, I put up inverted commas for those listening to this on a podcast, on audio, would be a wonderful segue into a lifelong prescription of a drug that I may never even need to use. And I know you're going to be talking about prevention and all of that, which is great. But I can see, I know this anyway, but I can see why you may have been a little disillusioned with the way medicine was being practiced.
Yeah.
What are your thoughts about that? Putting aside the extreme cases of fracture and your own experience, do you feel like we may be overdiagnosing this condition? It's very real. It's a real problem. But
yeah, I think there's two sides to this story, Ron. I totally understand where you're coming from, and that's kind of my approach. I don't see osteoporosis as a disease traditionally, inverted commas. I see it more of like a condition of bone deterioration that we can adjust. But when we look at a medical doctor, they're doing the best that they can with the time that they're given, the information that they have, the fact that they're being judged by a body of their peers, and all these different factors and also a patient who comes to them who says, you know what, I don't want to do all this exercise and this food. Is there a pill? They're going to give you that. And that's kind of the general kind of the people that generally see a medical doctor, kind of fit into that category. The people kind of listening to you, Ron, and people like yourself, that they're more proactive with their health. They're more interested. They're taking ownership of it.
Yeah.
And the frustration for me is when someone in that position goes to a doctor and says, I don't want to take the medications, at least not just yet. What else can I do? And they're like, well, you're on your own, Tom.
That's it. Which, Tom, brings us back to you being given 6 months by your endocrinologist. And I'm intrigued. I've got a feeling I might know that this worked out well. Otherwise, we wouldn't be talking. But tell us what happened. Tell us what happened. So
you got 6 months.
Months.
This thing doesn't make any sense. I kind of conceptualized it in my own head, what I needed to do. And it comes down to kind of a triangle of 3 components. Number one, we need to remove the obstacles to strengthening bone. And this is any of the medical conditions that might be, or hormonal imbalances that might be leading or contributing to it. Once we need to address that, we also then need to trigger bone growth. And this is what I started to do. If it turned out that I had no particular reason causing my osteoporosis, so it was what's called idiopathic, or as one of my professors in medical school used to say, the idiots don't know the pathology, so they call it idiopathic. And so I had the green light to build bone, in my opinion. And so it became about triggering bone growth. So bone doesn't spontaneously grow. It's like a muscle. If we don't exercise the muscle, it's not going to grow. If we don't exercise and put pressure on the bone, it's not going to strengthen. Even if we remove the causes of osteoporosis, we need to put pressure on that bone through specific and correct exercise, which is doable no matter how weak or fragile your bones are, mind you, right? And the research is very clear on this.
Yeah.
That's one thing. The other thing is actually giving the bones the fuel or the building blocks they need. And it's not just as simple as calcium and vitamin D, although they're very important. There are a whole lot of other vitamins. And then also what's often missed, and particularly in the elderly populations, is protein. Right?
Interesting.
I know, Ron, you've had people on before who have spoken a lot about the high carbohydrate, low fat and protein diets, which is complete, potentially dangerous for people's health. And I'll put that lightly out there that way, but it's very important to shift the way that we're eating to increase the amount of protein we're having, good fats and carbohydrates only depending on kind of our activity levels and what we're doing. And then adjusting as we go and getting checks on a regular basis. And this is where the medical kind of profession is yet to catch up as well. DEXA scans, it takes 2 years before you can have your next one. But there are better ways to kind of test your bone along the way. And so that's important to test and adjust and work with some professionals to help you to kind of implement that. And that's what I did. So through the right exercise, through the right fueling of my bone, giving it the right kind of macro and micronutrients, removing the obstacles, I then had a DEXA scan. I was a little bit sneaky in that I got it done 6 months rather than the 2 years. And the results had improved in only 6 months. I was out of osteoporosis into osteopenia, and I went back to my endocrinologist and I slid the results across the table, and with a big smile on my face and kind of expecting a well done. And understandably, he was very kind of reserved and conservative in his response.
Did he dismiss it as a placebo?
Well, no,
although how that could be,
Well, I'll tell you what, Ryan, with the amount of work I did, those bones, there was only one way they were going to go, and that was to get stronger.
Yeah, no, great.
But no, he said, I'll throw you a party, Tom, once they're back to normal. And only recently, my hips are back to normal now.
Great.
So, but my lumbar spine, I'm right on the edge of normal.
It's interesting, those three things: obstacles, trigger for growth, and building blocks. I'm just still intrigued coming back to, and I think what you've done is truly inspiring, and, shame on the endocrinologist for not embracing it as part of his own treatment protocol. But leaving that aside, the obstacle is an interesting one because, as you were telling me your story, and I've got some familiarity with nutritional environmental medicine, something that came to my mind was two things. One would have been, well, three actually. One would have been a gluten intolerance, not necessarily celiac, but a gluten intolerance. The second would have been poor vitamin D levels, and that would have been around the sunshine area there. And the other one could have been magnesium. But what was your gluten situation there? I mean, you weren't celiac, but
no, yeah. So for myself, I figured out that there were a number of, stacked up a number of potential kind of causes that individually they're okay, but altogether they led to osteoporosis. Yes, so I was gluten intolerant, and I still am. I had a scope done to confirm that I'm not celiac, but I am intolerant. And so for many years, I would start the day with, I think it was like 8 Weet-Bix or something. And then I was just inflamed all day. To add to that, I was in my 20s and 30s, I was against milk. I was against dairy for whatever reason, right? And so I didn't get much calcium, which is our main source of, milk. Dairy is our main source of calcium. So I wasn't getting much of that. Plus, I was really I was inside, like you said, a lot. I was preparing for studying the
Yep.
medical degree, good
Yeah.
hospitals, low
We've all
vitamin
been
D.
there. We've all,
I was
yep.
pushing myself, exerting myself, a lot of stress, and that can contribute as well. My testosterone levels were not below normal, but on the cusp of low, right? Just on the cusp. And this is something that a lot of men experience, especially as they get older. Testosterone does protect a bone. Um, and so for me, adding all those up, it's the perfect storm for osteoporosis.
Mm.
But generally speaking, like, in terms of the risk factors for osteoporosis, the main one is your gender. So women, as soon as menopause arrives and the estrogen levels drop, it's a high probability that they will develop weaker bones because the estrogen protects the bone. And when there's less of that, there's more bone turnover and breakdown. Then there are other risk factors like smoking, alcohol, stress levels. Then there's also glucocorticoid, steroids, different types of medications can contribute to it. For the gentleman, the big one that we see, if they have prostate cancer and they go through the hormone treatment for prostate cancer, which drops their testosterone levels, they often treat their cancer, but they end up with broken bones and osteoporosis. There is a whole range of risk factors, but
So when you said it's like obstacles for you,
Mhm.
I mean, if you're looking for the obstacle, but when you add up all of those obstacles,
Yes.
that starts to paint a picture of a high risk individual who's obviously genetically predisposed to express it in this way. Others might have expressed it in a different way.
Yeah, potentially. I mean, there's no osteoporosis in my family. My
Interesting.
mum is very proud of the fact that she has no osteoporosis in her late 60s,
Yeah,
and my
great.
dad and no one else. But yeah, definitely that if you put that picture together, and this is where my kind of personal mission comes in. Firstly, I want to make osteoporosis a truly reversible drug-free condition.
Great.
And then
Love to hear
secondly,
that.
I want
Music
to
to our ears, Tom. Music to our ears.
and secondly, I want the medical profession to see it that way as well.
Well, gee, I'm not as optimistic there. But this is why we do this podcast and this is
Yeah,
why we talk to people like you. The triggering of the growth, I mean, gee whiz, I'm just so impressed by what you've achieved, what you achieved. And you mentioned, irrespective of your particular fitness or age levels,
yeah.
what were some of the things you did that worked? Bearing in mind you were 30 something at the time, late 30s at
Yeah.
the time. What
Okay.
did you do?
So first step was to get me moving because I was in a very deconditioned state. I was, a young man. However, I hadn't been looking after myself in the previous few years. I just had a child and running a business and just all the pressures I'd given up on looking after myself I worked with an exercise physiologist to try and get me moving, and it started with really basic things like getting my core working, so bending over with a broomstick along my back, like really basic things. I'd previously fractured both ankles with no rehabilitation, so I
Wow.
couldn't hop on one foot. And so we started to rehabilitate some of these problem areas. Many of the men we speak to, they might have bulging discs, bad knees, hips, backs, whatever it is. We need to firstly start to address those problem areas. Then we need to start to put on some pressure on those bones with some weight bearing exercise. So strength, we kind of broken it down into into a progression stages. Firstly, are those foundations where we address those problem areas and start to build the core strength. Secondly, we start to work on just general strength and weight bearing, so that we are starting to put pressure on the bone, moving the limbs and the different joints, and that in itself can start to can stop the bone loss. And then we start to really step it up, and this is where it gets exciting, where the bone starts to really grow when we have more heavy exercise and impact exercise. So the impact are things like hopping on one foot, box jumps if we can do it, heel drops, so putting pressure and kind of like sending a bit of a pulse through the bones to give them that trigger to say, hey, this person's serious. We need to start strengthening the bone. And there are studies being done on this. There's a great one called the Lift More trials, done by an Australian professor and Dr. Belinda Beck from Griffith University. She is a world leader on this stuff, where she took women from different levels of osteoporosis and put them through this high impact resistance training for a course of 12 weeks, and found that the bones, the results were amazing, as good as some of the medications. And that's kind of my interpretation. That wasn't what they're very conservative in their discussions on this, but I was very excited by those trials. And then they did the same for men. And so the evidence is just building and building that you can, and we should be, first port of call for those patients who are willing to do it as well, is that exercise.
Hi, Dr. Ron here, and I want to invite you to join our Unstress Health community. Now, like this podcast, it's independent of industry and focuses on taking a holistic approach to human health and to the health of the planet. The two are inseparable. There are so many resources available with membership, including regular live Q&As on specific topics with special guests, including many with our amazing Unstress Health Advisory Panel. Now, we've done hundreds of podcasts, all worth listening to, with some amazing experts on a wide range of topics. Many are world leaders. But with membership, we have our Unstress Lab podcast series, where we take the best of several guests and carefully curate specific topics for episodes which are jam-packed full of valuable insights. So join the Unstress Health community. If you're watching this on our YouTube channel, click on the link below, or just visit unstresshealth.com to see what's on offer and join now. I look forward to connecting with you. The flow-on effects of exercise, I mean, we've done programs on sleep, many, and the flow-on effect of that, of a better night's sleep, are huge. The flow-on effect on mental health of exercise are huge.
Yeah.
And here we are on blood sugar, another one, huge. Yeah. And here we are, another one on osteoporosis. So there's really very little very little downside. I'm trying to visualize you having broken ankles, hopping around on one leg. You must have done little hops, very little hops.
Oh, I didn't go to hopping. It started with just balancing on one foot. It was very basic stuff. And then slowly, when I was able to stand on one foot, I think we then progressed to maybe hopping. I can't remember exactly what it was, but it was very progressive, steady kind of. Now I'm standing on. I don't know if you know what a Bosu ball is like. It's like it's a flat surface with a ball underneath. I'm standing on one foot on that with balancing weights, and so but that's probably, it started off with me literally bending over with a broomstick along my back. That was as good as I can do. And so that's really important for people to understand. We need to start slowly and work with a professional to make sure that you're doing things that are adapted to your needs, but are headed in the right direction, so that we are putting the right kind of pressure on the bones to give them the signal to grow.
I mean, and here we are, 4 or 5 years after you've been diagnosed. I'm hoping that your endocrinologist has put on a party for you. I'm just intrigued, because your numbers must be looking very good.
Yeah.
What's the endocrinologist's comment on this?
Well, I'm waiting till my lumbar spine is back to normal, and then I'm going to reach out. Right. But I haven't been back to see him for a little while. Look, he did his best, and it's not him personally. It's the way that the process, that kind of the expectations and the limitations and the processes, the system is set for doctors, that
Yeah.
I can see why they don't do anything else. Like it's
Yeah.
really, yeah.
Now you mentioned triggering growth and this importance of well-designed, curated exercise, but the building blocks. What about the building blocks?
Okay, so the building blocks. The way that I think about it is, it's like a construction site where we're building a house. You can have all the workmen there ready to go, but if they don't have the bricks, the wood, the timber, they can't get it done. And so, for the bone, there are a couple of key requirements. Firstly, is calcium, right? And this is irrespective of if we're deficient in calcium on our blood tests, because how we, you know, osteoporosis is often caused by the removal of calcium from the bones, and so the body needs a constant supply of it, because the body will do whatever it takes to maintain that normal blood calcium level. It so much so that it will draw the calcium out of your bones, right? Because the bones are like a reservoir and a storage facility for calcium, and not just a structural support, and other minerals as well, like magnesium, which is really important. So calcium supplementation is really important. Vitamin D, which gets the calcium out of your gut and into the bloodstream, is important. Magnesium supports it in doing so as well. Then we need vitamins like vitamin K2, which puts it kind of sends the calcium from the bones, from the blood into your bones. And yeah, there are a couple of other vitamins that that are a bit more controversial. Or my personal opinion is I like to keep it simple.
Yeah, I like that.
There are the two approaches. I call it the Spartan approach versus the kitchen sink. I want the stuff that's going to work, and I'm sure it's going to work, and it's going to work for me. And I'm not just throwing things in just because people say that we should throw them in. I'm like, let's see what actually works. And so I like to keep it simple for us. And that's the kind of the micronutrients, the macronutrients. Protein is the biggest one. There have been studies done on men who, and women too, who exercise and don't take extra protein, whether whey protein or hit a particular amount, versus those that do, and the results that from those who are exercising with the right amount of protein, their bone results are far better, and so it's very, very promising there.
Well, I know this has been excuse the pun, but a movable feast here about protein levels over time. And I know that the levels of protein are said to... What is an appropriate level of protein for a person to aim for?
Okay, yeah. So
how do you quantify it? How do you quantify
it's going to be different than the recommendations.
That's all right. Hey,
Yeah.
Listen, forget the recommendations tell you to stay out of the sun and take bisphosphonates if you've got osteoporosis.
And eat carbohydrates,
and eat carbohydrates. So forget about the recommendations. This is what we're interested in: health.
Okay.
This isn't about a business model. This is about a health model.
So 2 grams per kilogram of
Interesting
of body weight, of target body weight. So that's target. So if we're trying to lose weight, what's that target weight? If we're trying, for a lot of the osteoporotic men, we want to put on weight, and women as well and lean body weight here. Okay, this is where people get a little uncomfortable because we don't want to put on weight that's just extra energy. We want muscle mass, lean mass. So we want to eat 2 grams of protein per kilogram per day, which is a significant amount.
That is.
Compared to what people are usually getting in. And the key is in how to actually do it and spacing it out throughout the day, and then supporting, making sure that you have the right kind of foods and preparation so that you can do that. And that the way that we think about it is, let's do that for this kind of acute 2 to 4 year period of time where we're getting the bones back, and then we can reassess. Is that required at that level? Or can we adjust it at that point?
I mean, I think that people may miss that very important caveat that you put on, the target body weight. It's not your body weight at the moment. If you're grossly overweight and you're thinking 2 grams and I'm, 100 kilos, my God, that's a lot of protein I have to eat. No, if your ideal weight was 75 kilos, that's what you have 2 grams of, not your,
Yeah.
yeah,
No,
you,
that's it. That's it. It's
that's
the
a really
ideal.
important point.
That is the key. And the other thing to add to that is let's say you're going for 75 kilograms, and so that means 150 grams of protein. That doesn't mean 150 grams of chicken,
No.
right? That's just the
Oh, that's right.
protein component of your meal. So just to kind of keep it, again, I like to keep things simple. For me, I think 30% of the cooked weight of meat is protein. And if I kind of generalize that, it kind of hits that about that target. So if I'm eating, a 90-gram, if I'm eating, let's say, 100 grams of chicken, cooked chicken, 30 grams of that is protein.
Mhm.
And if we're going for 150 grams, that's 5 times that serving in a day. So it's really important to get the protein in the morning, in the lunch, in the dinner, and then snacks in between, potentially protein shakes, that kind of thing.
Hmm. No, that's quite a. It is. It's a bit like when we're measuring carbohydrate. I mean, people say low carb. What does that mean? Well, in my book, it means somewhere around 70 grams a day is achievable, sustainable. What does that mean? Well, it means you've got to spend about a week or two, not the rest of your life, a week or two measuring out
Mhm.
what it is you're eating to educate yourself. Because after 2 weeks, believe me, you've got a pretty good idea of what you're eating. You drive
That's
yourself
it.
crazy. So the same goes for the adequate protein. What about fat? We hear a lot about fat, and apparently, I mean, we've done programs on the importance of fat soluble vitamins like A, D, E, and K. A, D, E, and K. To absorb minerals. We need fat soluble vitamins to absorb minerals. But what about fats? Where should we be looking for fats?
So the way that I eat my fats is firstly through natural sources as much as possible. So avocados, virgin olive oil. I'm not against animal fats either. I think the tide is turning on some of the saturated fats in animal fats. So through fish and I love a steak. That every now and then that's great too. Some coconut oils as well. It's just a limited amount, and it's more so about so that firstly it's the type of fat. So staying away from seeds and processed oils. That stuff is like, yeah, we want to stay away from that. And the more natural, the better. And the amount is also important as well, and understanding where it's kind of sneaking into our foods as well. The way that we kind of try and conceptualize it is a thumb piece of fat with dinner or lunch. And oftentimes, if you have enough proteins, if you're having the right amount of carbs, you only be able to stomach so much fat. Like it really fills you up. And so you probably won't be having too much of it if you're kind of structuring your meals in a very purposeful way.
Hmm. You've also mentioned testosterone, and we've done. We had Dr. Rob King on, who's a men's health specialist, and he talked about testosterone levels.
Mhm.
And I had to admit that in all of my, whenever I'd seen my doctor, very rarely had the box been ticked to check my not even my vitamin D, because the Australian government won't support that wasteful thing of checking someone's vitamin D. But testosterone's another one. How do men improve their testosterone levels?
Yeah, I hear where you're coming from there, Ron. When I asked to get my testosterone checked, my GP looked at me and said, "Tom, you look like a man. You've got
Yeah.
the. I don't think we need to check your testosterone levels." I thought
Right.
it's not.
And you see, isn't that great that the doctor had been at medical school in 5 years and diagnostically could pick that up really well? I mean, you've got to
I'm
hand
glad he
it to
was there for that lecture, right?
you've got to hand it there for the medical education. It's really knows how to identify gender, which is quite a challenge in this day and age. But that's a different program. Go and tell us about testosterone.
Yeah. Okay, so increasing testosterone levels, it's we have to understand kind of how they build. So firstly, how you mentioned fats. Fats are the building blocks for hormones. So we need to get in the right amount of good fats. Secondly, we need to start taking exercise. Heavy kind of lifting exercise stimulates testosterone improvements and growth. Supplementing with zinc is also, it's a secret kind of a men's supplement. It's not spoken about in the women's osteoporosis space, but men require zinc. And that, classically speaking, when you think of, the oysters being, this aphrodisiac, because they're the biggest source of zinc. But I mean, other than oysters, it's best probably to supplement. Now the testosterone space, if you Google search how to increase it, it is all kinds of crazy things come on out there. But we really want to keep it simple and keep it kind of healthy and based on what's been shown. It is very limited in terms of other than hormone replacement therapy, which is often, it might end up being something that some men go for, but there are definitely things that we can start doing. Improving sleep is another one, right? So they're the kind of the four main areas that we talk about. Right kinds of fats, the right kind of exercise, which in itself triggers it, zinc supplementation, good kind of good sleep. Even napping during the day has been shown to boost men's testosterone levels, funnily enough. So good quality sleep. And starting with that is a great way to go.
Another example, I think, I'm sorry if I sound like I'm having a go at some public health measures that are touted, but, a precursor to testosterone is cholesterol. You need healthy cholesterol. You need cholesterol to have healthy testosterone levels, which kind of puts the statin lower cholesterol to as low as you can get. I once heard a heart specialist, not one that we've had on this program, because that's Dr. Ross Walker, who annually comes to see us on the program. But I've heard one heart specialist say, I just cannot get my patients low enough. The lower, the better. The lower, the better. So can you imagine what that's doing to people's testosterone?
Wow.
I know. Wow. That's we almost should have a minute's silence after a statement like that.
I can't help myself but have a minute's silence.
Yeah, that is extraordinary, isn't it? But there's a few things there, because we really don't test for testosterone, and yet it's so critically important for so many different levels. It's kind of almost a parody. Oh, your high testosterone levels, isn't it? But we need testosterone as men.
Yeah, and it can't just be low. Normal is also a potential problem. If you have the symptoms, you then essentially have low testosterone, right? And any of the symptoms, if we put it that way, of aging has often been have now starting to be shown to be caused by low testosterone levels in men. And so it is very important. And part of my mission, as I was saying, was changing the way that medical practitioners are thinking about osteoporosis, particularly in men. And I want them to be thinking about the risk factors and the potential causes of it. And low testosterone, particularly if someone's had prostate cancer, for example, if there are very specific reasons for it, then testing for that should be part of the normal workup. And almost like the screening process for if a man over 50 has come in with a broken bone, let's start screening for osteoporosis, and potentially even earlier if we're thinking about the risk factors and what's going on here. We have a lot of men coming to us who are younger, who are frustrated because they don't know what's going on. Their doctor kind of threw up their hands, not sure what to do, and just take the medications. And they've proactively started to kind of take ownership of their health and say, what's going on here? And it comes together. What we kind of start to realize is that there are all these different things that add up, that we need to be thinking about. It's and I empathize for the doctors, because there are a lot of things they need to be thinking about at the same time, probably far more serious. But at the same time, over the next 10 years, osteoporosis is going to become a big topic as people get older and they keep breaking bones. And as you said, the system is set up for the risk factors for further breaks of bones, and it's just going to become a a big topic.
And it's so interesting too. And this we're going to talk. I want to ask you about mindset as well. But doctor, you had this burnout, and we've done programs on burnout, characterized by the acronym DIE, disengaged, feeling disengaged, ineffective, and exhausted. So if a doctor is thinking that, and I'm not surprised really, because writing out prescriptions and on a revolving door of patients coming in for the next prescription must be very disengaged, feeling ineffective and quite exhausting. So, I mean, mindset and motivation are key, aren't they, here? And what do you say to people? I mean, how do we get started on that? How do we engage with that?
For medical professionals or for patients?
Well. Your background is medical profession, but I'm saying for your patient, for patients who are facing this with the alternative, go down this way or go down this way. The difference is in your mindset.
Yeah.
How do we change that?
Burnout is a very interesting topic.
Hmm.
And I think that so I've previously spoken to doctors about burnout. I've put together some education for them about it, and a lot. It's part of. It's seen as a normal part of medicine. You get burnt out, you kind of recover, and you get back to it, and you kind of go through these periods of burnout and then coming back in. Now, different people kind of address this in different ways, different doctors. But in the last 5 years, there has been more conversation about it, more openly talking about it. And I used to refer to it as high functioning burnout, where they're still pushing through, getting things done, but they're feeling miserable, unfulfilled. And I think that's kind of what you were trying to get to there. Was it's very unfulfilling to be just churning through and frustrated. Unfulfilling and tiring, and there is this kind of being overworked and overstimulated and not enough downtime. And one of the things that we spoke to doctors about is, I once put together a program where I was saying to doctors, all right, if you're so burnt out, let me show you another way. Here's what I did. I left medicine and I started my own business, and I kind of took my experience with gut medicine and kind of turned it into something that gave me a life that didn't lead to burnout. But what I realized is that they don't want to leave medicine. They love looking after patients. They want to do good for their patients. They want to look after them. They just want to find a way to do it so that they're not burning the candle on both ends. And so one of the things that often kind of and I don't want to simplify, because there is a lot more. There could be some depression kicking in at this point, all sorts of other kind of mental conditions. But that's where it becomes difficult with medicine, because if you are in any way impaired, you can't practice, and we shouldn't practice. And so it's a very sensitive topic. But in terms of preventing burnout and going to that extreme, then there are things we can do, like taking a break, inserting activities that we enjoy, making sure that we're looking after ourselves in terms of sleep, food, and exercise. It's very easy, particularly in a hospital system, to just grab whatever is there. And it's usually, carbohydrate-laden foods from the cafeteria or things that are easy on the go. That there's a whole lot of pressure to keep working and working and working, and not take breaks. Breaks are important because it does kind of rejuvenate. And a lot of the medical professionals that I've spoken to, if they do take a holiday, and it seems a little simplistic, and I don't want to oversimplify it,
No.
a holiday does make a big difference. Changing the work environment as well, understanding their own limitations and what is the right kind of work and the right kind of way that they do work, but also, looking after those foundations of sleep, food, and exercise, and building kind of this way that they do life and understand their own, almost like a thermometer of burnout. Because I don't think that we'll potentially get to a point where we're not kind of pushing that burnout level, because a lot of doctors are high achievers. They want to do this. They add things to their plate. We're talking to doctors before and taken a whole bunch of things off their plate and saying, hey, you got this extra time. they fill it just like that with other activities because they love to be busy. They've got all these ideas and things they want to do. And so being able to understand their own kind of signs and the different symptoms that they're experiencing to go, okay, I need to pull back on this. I need to kind of slow down on that. And having someone in their life is very important who understands that as well and can be almost like their mirror. Who can say, hey, hey, Tom, you're kind of going a bit, you haven't been sleeping as well as you used to. It's hard. Let's kind of look back at your days and how have you been eating regularly? Have you been exercising? Have you taken time out? What kind of tasks are you doing that are kind of overdoing it for you? And just kind of getting that, navigating through life by knowing where those limitations are, and then working within those. And also sometimes, and again, the high achiever thing comes in. We want to test our limits. We want to kind of see where we can go because we want to keep growing and improving. And so understanding that if we do push those limits, there will be a period of recovery that has to come up and almost forgiveness for yourself that we can't keep pushing. We do need to kind of stop and rest at times as well. So I kind of went on a bit of a rant there on.
No. I think that was that. Look, I think that is actually a great note for us to finish on, Tom, because it's a great message not only for the medical profession, but for anybody who is trying to overcome a diagnosis of a chronic, preventable and reversible chronic disease, which you've outlined for us today. So thank you so much for joining us.
Thank you for having me on. This has been fantastic. Thank you.
Well, isn't it interesting that we have recurring themes on this podcast? We've spoken to many people with the supposedly irreversible type 2 diabetes. Irreversible, that is, until the doctor themselves experiences it, explores alternatives, specifically a low-carb diet, and miraculously, what was previously thought of as irreversible is now reversible. And here we have another story, osteoporosis. Again, often thought of as irreversible, but here we have Dr. Tom very clearly demonstrating that through a whole range of accessible, not unconventional at all, treatments or lifestyle choices of exercise and nutrition, that he was able to reverse that, much to the surprise of his endocrinologists. But one, I'd be fascinated to know what impact that surprise had on the endocrinologist's own professional journey. This is such an interesting story because when I was listening to Thomas's history, the first thing that came to my mind is to why did this occur? And although he initially felt that there was no obvious reason why, the first thing that came to my mind was that perhaps he had a gluten intolerance. Now, whether that was strictly the celiac, which is the complete loss of the villi, which help you absorb your nutrient in your gut, you can have something called non-celiac gluten intolerance, which means you also don't absorb your nutrients as well. And I became aware of this because of some patients, despite having a good diet, are much more susceptible to tooth decay than those that are not looking after their teeth perhaps as well as they could or should, and yet don't appear to have any decay. And why is that? Well, when the teeth are laid down in the first 5, 10, 15 years of life, when all of the permanent crowns of the dentition are laid down, if you have an intolerance to absorbing your nutrients efficiently, then that will affect the hard tissues in your body, like teeth, tooth quality, and here we have bone quality as well. So there is a reason, and it takes me back to one of my mentors saying to me that if you ask your patients the right questions and you understand their answers, then you will uncover the story that they tell. So this was a great story. I'll have links to Dr. Tom's whole program where you can get a free report and a program, and I think it's an inspiring story. I hope this finds you well. Until next time, this is Dr. Ron Ehrlich. Be well.
Feeling stressed, overwhelmed? It's time to unstress your life. Join the Unstress Health community and transform stress into strength. Build mental fitness. From self-sabotage to self-mastery. And together, let's not just survive, but thrive. Expert-led courses, curated podcasts, like-minded community and support, and much more. Visit unstresshealth.com today. This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.